All right, so I'm going to go ahead and get us started. Welcome, everyone. Thank you for joining us today for our fourth session, examining the intersection of substance use disorder and women's reproductive health. We are co-hosting this with the Center for Public Health Practice at OSU, and I work for the Center for Health Outcomes and Policy Evaluation Studies. So we've been working with a lot of different partners to develop this series, and I would like to just acknowledge them all on this slide. And then just some technical information I'd like to go over. The session is being recorded. You should have gotten a little notice about getting permission to record this, and we can email it to you along with the slides after. All the participants and attendees are automatically muted and the video is disabled. But if you have any questions, please put it in the Q&A function or the chat, and we will be monitoring that and getting your questions to the right presenter. And then for CEUs, you need to complete an evaluation that I will also email out to the list of attendees. And the CEUs will be processed at the end of our series in December. So this is our agenda for today. We are going to hear from Laurel first from Planned Parenthood of Greater Washington and North Idaho, and then Tanya, who is from Planned Parenthood Federation of America, followed by Lisa from the Baltimore City Syringe Exchange Program, and finally Deena from West Virginia Bureau of Public Health. So I'm going to stop sharing my screen now, and then we'll let Laurel share her screen and she'll begin her presentation.
Good morning, everyone. I'm on the West Coast, so it is morning time for me and I think afternoon for you. Did that work?
Not yet.
Not yet?
No. There we go.
Okay. So my name is Laurel Kelly. I am a licensed clinical social worker in the state of Washington, and I work for Planned Parenthood of Greater Washington and North Idaho. We are a clinic or an affiliate of Planned Parenthood that serves 11 clinics in Eastern Washington. Our region stretches as far as Yakima and Wenatchee, Ellensburg, if anybody knows Washington at all. So we have a large base of pretty diverse population, lots of more migrant farm working communities, different things kind of in our rural areas. But then our main services are populated in Spokane, which is one of the larger cities here in Washington. And I was asked to present a little bit about how we have started integrating behavioral health and substance use disorder into Planned Parenthood. So I will just go through these slides and feel free to, again, text in questions or send in questions if you have any. Essentially, let's see, did it go to the next slide?
Yes, you're good.
Okay. Why Planned Parenthood? So one of the things that we realized is a couple of years ago, Washington State did some pretty amazing work around Medicaid transformation. And Planned Parenthood was kind of asked to be a part of a process where we recognized that a lot of our patients in our reproductive and family planning clinics only come to reproductive and family planning clinics for any kind of health care. So that's a pretty big statement. A lot of, especially our women and gender diverse patients are really only coming into our clinics. They don't have primary healthcare providers or other people. So they're really coming in for birth control access, gender affirming hormones. And so they weren't necessarily going anywhere else to kind of be screened. And what we've realized is that 50% of the patients who receive a referral, so when they do come in, and we say maybe it'd be a great idea to go potentially reach out to a mental health counselor, substance use counselor. Most of them don't do it. And so they really want to come for one-stop shop kind of care. And with that, there's a fabulous center at the University of Washington called the AIM Center. And they really talked about that these collaborative care interventions are going to be very important. And especially when we started to screen for anxiety, depression, and anxiety and depression oftentimes go hand in hand with substance misuse. So we really need to be doing this kind of comprehensive screening. So Planned Parenthood was asked to kind of be a part of a process. We also know, as all of you do, that a lot of times people are experiencing co-occurring. So they are experiencing some of those depression, anxiety, alcohol, substance misuse, kind of all together. And it's one of those, what comes first? Is it the depression that comes first that then creates the use of substances, or is it the substances that come first that create kind of the depression and anxiety? But there is a major stigma across our culture and societies to talk about these things. And so we don't do a great job of always really trying to figure out what our patients are coming in for and how these other parts play a piece. So in Washington, we were really lucky that we have a governor and a process where we were able to pass some legislation. And so Planned Parenthood 2 years ago was able to qualify for Medicaid transformation dollars, which gave me a job, which was super great. And so I was able to start here at Planned Parenthood as a licensed clinical social worker and start a behavioral health program. And that started with us now saying, and our governor saying, that any agency that receives Medicaid needs to have integrated services for both physical health, mental health, and substance use disorder. This silo is a great version of Eastern Washington, but it's also what many of you probably experience across the nation and the globe, is that patients come into one clinic for healthcare, for physical healthcare, they come into another clinic for mental health care, and they come into another clinic for substance use. And that still kind of happens in Washington. If someone comes in here for potentially mental health care and reproductive health care, I oftentimes still have to filter them out to substance use care. We're working on building that process and changing that right now. And I'll share how we're doing that. So what we started doing was initiatives for addressing substance use disorders. And we did that through a couple of different things. We did pretty intensive staff training. So we really started to educate all of our staff about that people that are coming in are sometimes in distress, and so they need evaluations for more mental health care. SBIRT is a screening tool that is basically a brief screening tool for substance use that asks a couple of pretty general questions about drug and alcohol use, and then it gives us an overview if we need to kind of dig into that more. And we started to do a little bit more outreach and education in our community. And we did patient screening. I'll talk briefly that we did start to dispense Narcan, and I know Planned Parenthood Federation is also going to talk about that. And then started offering behavioral health services. And currently, through that same Medicaid transformation, I'm going through training to become a substance use disorder professional so that we can also offer that additional service. And our Medicaid transformation is really trying to get more providers kind of trained in that particular area. And then we've also worked really hard at creating kind of a patient navigator position. So that staff training, this is a really brief slide on what we've done. Our education staff has done quite a bit of education in our local youth homeless shelters. They've also done a lot of education in our juvenile correction centers. And unfortunately, both of those facilities are places where we also see a lot of young women primarily usually using or selling sex as a way to potentially get housing. We'll talk about that idea of survival sex. So a lot of our patients are coming in potentially in those different avenues. So when we do education and outreach in those facilities, we're able to kind of offer additional services and talk about what's there. The SBIRT is that screening, brief intervention, and referral to treatment for clinical staff. So all of our staff had to do, I think it was a free 4-hour online training. Basically, that tool now is utilized if if a patient identifies that they have a higher risk for any kind of substance use, then we can administer other tools. Like there's a tool called the audit, which is an alcohol assessment. We can also do another tool and then talk to the patient a little bit more about, are they in the stages of change? Are they ready to potentially make any difference? And then we also developed an MOU with one of our substance use agencies in town so that we can have a direct line connection so that we don't have to potentially have that patient wait for long-term to get in to be assessed. In terms of the depression screening tools, we also really started to do, like similar to most of you, the PHQ-2, which is 2 questions that are asked about people's mental health. And if they score on that, and then it kicks another 9 questions or 7 questions into that. And then that gives us a score. The last question on that is a suicide question. And so that then allows us to assess for suicide as well. And then we do the general anxiety disorder tools. So those are all things that we've kind of integrated into our reproductive health centers. They usually occur on all of our annual exams. Most of our gender affirming care are also being kind of evaluated. So there's lots of different places that we're asking more questions. And then we asked some questions about the audit there, which I'd mentioned, the DASH, which is the, are you currently using any recreational street drugs, including IV drug use, and then any previous, pardon me, IV drug use. Sorry, I just flicked through here, hang on. So Narcan, we did also receive some funding to be able to offer Narcan, which has been awesome. And since COVID hit, obviously all of our clinical practices has changed, but we asked the question if the patient is currently using or if they have a family member, and we have dispensed, I think it's about 70 Narcan, which may not seem huge, but in our kind of rural communities, that's a larger number of Narcan since January with COVID as well, which is a great tool to get out there for patients. And then this is the other piece, is our work with individuals who are identifying or working in either in prostitution or in the sex industry. Again, kind of a different population here in Spokane, what it looks like in your community. So I would encourage you all to really do an investigation of what that looks like in your community. We really have a population of people. We started asking the question, do you exchange sex for drugs, money, or housing? And in the time frame that we started asking that question, we've had about 150 people respond yes. And once they do respond yes, we're able to kind of ask a little more questions about safety. What does that look like? A lot of people do not identify themselves as doing sex work or doing any of those things, but potentially are engaging in that, again, survival sex. And we definitely find this in a lot of our younger population. They are really staying with somebody who's much older. They're doing different activities just because they need a place to stay and housing. And so how do we reach out to those people? How are we making sure that they're having access to both reproductive health care, sexual health care, and also mental health services, as well as substance use? We used to have a partnership and still work pretty closely with our needle exchange program here in Spokane, and do a lot of outreach, again, in our rural communities where we are often asking these questions. Human trafficking looks different here. It's not kind of what you would anticipate in other communities, but we definitely have people that are engaging in survival sex. And so what does that behavioral health look like? We now have, I'm excited to say, 2 full-time behavioral health specialists that are really able to kind of dive into this a little bit more. We provide counseling for anxiety, depression, PTSD, trauma, other mental health conditions. We also were able to hire a primary health care provider who prescribes some of those mental health medications, and also able to get a patient navigator. And that patient navigator is somebody who, if I find somebody that I'm struggling with homelessness, or they're struggling with other issues, we can kind of help get that person into the right resources in our community. So that is another person that we have hired that is kind of helping do that. So kind of that's a real quick overview of what we're doing to hopefully be doing more outreach and integrated services for both women and men working in the sex industry, but also providing behavioral mental health services in general.
Thank you, Laurel. I have 2 questions. Can you talk more about that MOU that you have with the treatment providers, and then also what your relationship with the needle exchange program has been like, and what specific services you're providing together, how you might be tracking that, and then also some next steps for your office if you have any to share.
Yeah, great questions. Our relationship with establishing that MOU was that we, again, in Washington, we struggle with mental health services are offered in one avenue, and then chemical dependency services are offered in the next avenue. And so it's a challenge when somebody comes in and, again, has substance use issues. If I really want to get that person in treatment, they have to go through this entire assessment through chemical dependency. So that is partly what we are getting trained in as staff right now, so we can start to offer that service in the future. But, and it's actually really wonderful. Our state has also created a fast track for that, because there's a huge need for more chemical dependency professionals in our community, which are now called substance use disorder professionals. So we keep changing our language. But the MOU was that we reached out to another a treatment facility in town, and they were very excited to say, okay, if you have a patient who comes in that we want to get them instantly into treatment, or at least get them assessed, we can kind of streamline that process. The advantage has been in our community that we are one of our, the only gender affirming care providers in our community. And so they were also really excited to say, hey, our patients who are needing gender affirming care, we'd like to kind of streamline them to you. So finding that, what do you each have to offer to come together and then find a way to create that partnership has been really great for us. The needle exchange program, we're not as involved in as we used to, but we did used to have a needle exchange van that would go actually travel and work with women and men in prostitution. And this has been several years back, but part of our education team did used to go out on that van. The van is no longer in operation, but they now have a site at our regional health district. And so we work really closely with the health district here and doing both education and back and forth. So we have information there, they have information here. We've kind of really tried to create, again, a partnership. But there was a time when we were actually able to travel, talk about emergency contraception, talk about, safer sex practices, all of those pieces when we were out in community working with men and women in prostitution. And so now that the exchange center is kind of set a site, we're not as involved, but the hope is, I think that's a great way. I think having a reproductive health educator or anybody on those vans or in those outreach places is a great idea. And then I'm sorry, what was your third question?
Yes, I said I only had two, but I actually had three. My third question was any next steps for your program for expansion or different partnerships?
Yeah, that's a great question. I think I would highly recommend that any of you that are working in reproductive health, that you really think about hiring some mental health providers. I think that there is a desperate need in the integration of care. And so what we have found is a lot of our patients have been so thankful because they're now coming to, again, one place where they weren't necessarily following up or going to any kind of behavioral care or substance use care. They're coming in here with high-risk sexual behaviors. And so just to get them integrated right into behavioral health and substance use care right here is going to be really powerful. And so finding those partnerships and ways to do that. Our expansion is that I was a one person shop, and we just hired a new provider, which is exciting. And the goal is, as this kind of continues to build, again, we're in several rural communities, and so we have a large Spanish-speaking population in Eastern Washington. So finding ways that we could do more outreach and integrate into some of these other areas, especially to find some of those populations that we're not reaching right now. So yeah, I would say that would be our next step.
That's great. Thank you so much.
Yeah.
So if I get other questions from attendees later, I can hold them till the end, but right now we'll have Tanya speak. Laurel, can you stop sharing your screen?
I think I can. Yeah. Let me see how I do that. Hang on.
I think I could do it actually. Let me see.
Yeah, you could take over and not.
Yeah, that'd be bad.
Okay, great. Thank
Okay,
you,
so
Laurel.
can you now see my slides?
Yes, we can.
Awesome. All right. Well, good afternoon, everybody. I'm Tanya Harris. I'm a national director here at Planned Parenthood Federation of America. I'll explain a little bit about our organizational structure here in a minute, but I'm super excited to be here with all of you. And I'm coming to you from the coast of Delaware, so on the other side of the country. And so I'll go ahead and get started. You know, I've got some slides here, and some of them are a little outdated just because of the nature of the crazy year we've all been having. But I'm just going to start and sort of say some things that perhaps go without saying. But this is not the first time the United States, this is not our first rodeo with opioid addiction. And if we had treated the first round of heroin addicts as a public health issue rather than a criminal one, we might have learned more about effective treatment before this current crisis that we have found ourselves in. But instead, we have over 1.5 million people who have been arrested, prosecuted, incarcerated, and placed under criminal justice or supervision and deported. So again, recognizing some of this information may be a little bit outdated that I'm sharing with you in terms of slides, but I'm going to talk you through sort of what we are doing currently in Planned Parenthood. So let's talk a little bit about who we are. Obviously, you just heard from Laurel, and amazing work that's happening in Washington. Planned Parenthood is a national network of healthcare providers. We have over 600 health centers all across the country. And we are organized sort of into affiliates. So there are 49 affiliates. So Laurel was speaking about her affiliate and the work and the amazing work that they've been doing there. But there's also just some things sort of about Planned Parenthood Federation, which is the national organization where I work that supports all of our affiliates. And there's some aspects of who we are and how we function in the healthcare environment that I didn't know when I came here 10 years ago that I thought might be a helpful sort of framing for this conversation today. We have a national medical committee. So you see it referenced here on this slide. And that's really a group comprised of volunteer physicians and clinicians who are experts in sexual and reproductive health. And they advise us on ensuring that our medical standards and guidelines are up to date. So we do have our own medical standards and guidelines. We reissue them every other year. And then we also have a robust accreditation team in the Planned Parenthood Federation, which accredits each affiliate every 3 years. And one aspect, a critical aspect of that accreditation process is ensuring that all providers abide by our medical standards. So I'm telling you this to sort of set up a little bit for what I'm going to talk about in terms of the work that the Federation has done, both to support and encourage affiliates in this space. So it's important to know that there are 12 core services that Planned Parenthood requires each affiliate to provide. But then there are always optional services that we're exploring either in response to community need or to national healthcare trends, or frankly, to sort of keep up with some of the amazing innovative work that's happening across the country at affiliates, including at the Greater Washington and Northern Idaho affiliate, as Laurel was just discussing. And so really what this is intended to show you is sort of to encompass, and we'll talk a lot more about this toolkit through my remarks, but this is really just to demonstrate what's involved in getting to a place where Planned Parenthood sort of provides this technical assistance to our national network around a new service that might be useful. And then as we talk more, one of the things that's relevant to know is that we have, out of the 49 affiliates across the country, 15 of them are now providing SBIRT and at 127 health centers. So we are seeing steady progress in terms of the pickup of providing services around substance abuse in our network across the country. So this is just a slide, that talks about sort of how the media coverage of this opioid crisis. Obviously, these days, we don't hear a lot about what's happening with opioids or other substance use as a result of the public health emergency that we're in. But just to sort of call out sort of some of the dynamics that we see nationally. And this chart is also somewhat outdated, but just for context, we now know that fentanyl and other synthetic opioids have become the most serious problem in the United States, in no small part because of the intense strength of these drugs. When mixed with heroin, fentanyl can be incredibly deadly. The US is also experiencing an increase in overdose deaths since the beginning of the COVID pandemic because so many people are isolating and using drugs alone. And the single most important thing from what I've learned about opioid use that you can do, that all of us can do if we have someone in our life who is a user, is to ensure that opioid users do not use alone. The risk of overdose with fentanyl is so high, and street drugs may be mixed with higher concentrations of it that can be safe, then they can safely tolerate. So if you know anyone, please work to ensure they're not alone when they use. And certainly, obviously, we'll talk a bit about Narcan, naloxone here too, and just, is widely available and incredibly successful at reviving someone experiencing an overdose. So again, this is sort of some of the context, running a couple years old, about sort of the national emergency and the degree to which we began talking a lot about opioids in this country over the last few years. And then I'm really going to get into the meat of sort of how we've looked at this and how we've looked to support a broad network of providers in getting comfortable with integrating some assessment of substance use into their health centers. Now, obviously, you saw from Laurel's presentation, they're doing amazing work and using a whole host of much more involved tools. But as perhaps I'm going to sort of assume most folks know, SBIRT is sort of I think it was putting your toe in the water, right, in terms of thinking about providing some initial assessment around substance use. So we'll talk from here about how we can drive change from a national level at our health centers across the country. So we have a medical services team here within the national office, as we call it, Planned Parenthood Federation of America, which will identify a need in collaboration with our policy folks and with, folks that run our healthcare operations consulting shop. And we've also usually in these instances heard from some of our medical directors and clinicians and physicians across the country about the new service that they've either sort of started to look at, or they really are hoping that we will do the legwork to develop a protocol for that service in order to help them provide it. And so then we go to our national committee, our National Medical Committee, who developed the specifics around sort of how far we go into different areas, because as a sexual reproductive healthcare provider, I'm completely in agreement with everything Laurel said about how many of our patients don't go anywhere else. But we also sort of have to always be balancing out the scope of what we do and where we go in terms of our work. And so, the example that I think is most relevant here is that we've done this work around SBIRT, but not around medication management and the provision of Suboxone or methadone, for example. And then we roll that information out as it's developed. So this is not a mandatory service for Planned Parenthood across the country, but it is an option. And the way that we roll it out is through something like this toolkit. So then when we get into the toolkit, there's a lot of aspects that we try and think through in order to support all of our health centers across the country. And one aspect, as you see here, is really on thinking about how to incorporate SBIRT into the course of a reproductive healthcare visit. Like the rest of the healthcare system, we are really committed to providing efficient, holistic care that addresses as many needs as possible during one visit. But this tool is really to help smoothly integrate SBIRT into a patient visit. And so you see there's sort of details here about how to do it, how to think about it, sort of making things optional, how to have conversations and that sort of thing. And then, of course, because no one can provide all of these services for free, here's the guidance that we've put together. We work with our public policy team. We work with our revenue cycle experts to really identify sort of the best guidance that we can provide around billing and coding out to the field in order for folks to do that, because each affiliated organization is its own independent 501c3, their own set of healthcare providers, their own insurance contracts, their own credentialing. All of those pieces happen at the affiliate level. At the Planned Parenthood Federation of America is not a medical provider in and of ourselves. So this is really a slide that's intended to demonstrate how we try and be holistic in this work, and as we think about all aspects of a new service, to make sure that we've considered things from all angles before we roll something out. So obviously implementing something like an SBIRT impacts providers, impacts healthcare assistants, impacts any staff working on referrals for services outside our scope. If you know, there may be some staff who are solely focused on referrals out into the community for various services, as well as the revenue cycle pieces that I was just referencing about billing and coding and reimbursement. There may be changes needed or enhancements to the electronic health record, both in design and in reporting. And then obviously there's always trainers who are entrusted to roll out new services to the clinical team. So I suspect, you know, we don't really need to explain what naloxone and Narcan are to this group, right? But just to recognize that this is a drug that had been used prior to the opioid epidemic as an emergency drug in case of issues regarding anesthesia and the like. And so this is a drug that a number of Planned Parenthood locations already had, but were not using it or thinking about using it in the overdose context. We have seen overdoses over the last couple of years happen in some of the parking lots of our health centers. And we have had folks ask for naloxone and Narcan prescriptions in order to be able to support their loved ones who are dealing with an opioid addiction. And now we do see that some of our health centers do keep naloxone on hand for those kind of emergencies. And although we don't have a toolkit and resources specific to naloxone at this point, we have shared this kind of information across our network for healthcare centers that are interested in having access to naloxone or interested in prescribing it. So this is just really intended to sort of give you a sense of how a large network tries to support folks in moving into providing more access to services around substance use. And with that, I will close. There's my contact information. I'm happy to hear from any of you if you have any specific questions about Planned Parenthood writ large. Although obviously you've heard from Laurel about the wonderful, very specific work that happens at one of our affiliate locations. And with that, Anne, I'll take any questions.
Thank you, Tanya. I have one question, and it's related to your comment about medication for addiction treatment. Do you have any insights on where the affiliation might move in regards to making that more accessible to women that come into your centers?
Yeah, it's a great question, and I'd love to hear, you know, Laurel's thoughts on this too. I mean, I think that, you know, as a provider that is known sort of for our reproductive health care, you know, there's always this balance about sort of how much we go outside of scope. I mean, we see this frankly even in the COVID space too, around, you know, do we serve as a testing site? Do we consider serving as a vaccination site? And there's compelling reasons on both sides. We, you know, as Laurel so wonderfully articulated, there are people that come to us that simply don't go anywhere else. But also because of who we are, there's lots of security concerns with having folks in and out of our spaces. And we have to be really mindful about sort of how open that we are in seeing folks that are not coming to us for our sort of core services. So I know that a number of folks around the country had really been trying to work out whether they could get into the medication management space and what that might look like. I feel like, you know, all of us in public health sort of stopped doing anything else come March, right? And it has just been sort of overcome with COVID ever since. So I don't have a sense of where folks are this very minute because, you know, the world has sort of, world events have overtaken us as of late. But I don't know if Laurel has any thoughts on that.
I would just say that we've begun some discussions, but we're not at a point where similar to what you said, we're not at a point where we're ready to kind of launch into that yet. There's so many other factors. And we do have providers, again, in our community that we can link patients to. Again, the hard part is getting patients to that sometimes, but would totally agree that we also are experts in certain areas of care. And so continuing to kind of remain focused in those, but building those services as we can would be great.
Yeah.
Thank you so much. And again, if I get more questions coming in, I will send them to you near the end of our session. But now I'm going to ask Lisa to start her presentation. And if you can go ahead and share your screen and get started. Thank you, Lisa.
Sure. Okay. Good afternoon, everyone. My name is Lisa Parker, and I'm the Assistant Director with Baltimore City Health Department Syringe Exchange Program. And I'm going to talk a little bit about our reproductive health services that our program provides to women who are injection drug users. So our mission is the Syringe Exchange Program with the Baltimore City Health Department. And I'm sorry, my slides are a little crazy, forgive me. Our mission is the Baltimore City Syringe Exchange Program. We are a harm reduction program and a prevention program for people who are intravenous drug users. Our program is an evidence-based intervention, again, designed to prevent the spread of HIV, hepatitis C, syphilis, and other bloodborne infection. Our services are provided to anyone in the community, not just people who are registered with our programs, and all of our services are free of charge and free of judgment. Our goal is always to provide culturally competent syringe exchange and harm reduction services to all of our clients, regardless of gender, sex, race, or sexual orientation. A little history about our program. The program began back in 1994 as a 3-year pilot program as a response to the high rates of HIV transmission among injection drug users. At that time, the HIV infection rate was somewhere around 60.4%, and today, the infection rate among injection drug users is a little less than 7%. Some of our client demographics, we have a 63% male population and 34% female. The average age of our clients is roughly around 40 years old. 46% of our clients are African American, 49% are Caucasian, and 5% identify themselves as others, including Hispanic or Asian. Some of the services our program provides, of course, are syringes and other safe injection equipment, reproductive health services, overdose prevention, education and response, and the distribution of naloxone, male and female condom distribution, health and harm reduction education, linkage to care, treatment, and support services, wound care treatment and referrals for medical care, capacity building assistance for other syringe service programs. We offer vaccine, flu, hepatitis A and B vaccines. We provide testing for HIV, syphilis, and hepatitis C. We offer assistance through a case management program called HCAM, where we work with community members as well as our clients to provide assistance getting identification, birth certificates, social security cards, and as I said, support in getting linked to treatment and other medical and mental health services. With women who are injection drug users and around providing reproductive health services, we had to be mindful that they have special circumstances. They have a greater risk of experiencing stigma. They are more prone to experiencing violence. They have a higher rate of mortality, and they have a higher risk of being exposed to HIV and other bloodborne pathogens. Most harm reduction programs typically provide simple HIV, STD testing, and linkages to treatment and distribute condoms, but they don't always address the other aspects of sexual health and wellness of women who inject drugs. Many programs don't address these challenges in assessing health care that some of these women may experience, the stigma that many of these women face, especially those who are pregnant, women who may be commercial sex workers and use that as a means of support, women with unstable housing, women that have issues around finding childcare for their children, and the other mental and trauma related issues that these women may face. Developing a woman focused comprehensive approach towards sexual health and wellness for women who inject drugs helps to support these women in living with addiction, lower their risk for further prevention for transmission of HIV and being exposed to other sexually transmitted diseases. So some of the services that our program provides, again, our reproductive health services began back in 2008 after again discovering that there was an unmet need for sexual health and wellness among exotic dancers working in the red light district in Baltimore City in an area called the Block. Our program, in collaboration with Healthcare Access Maryland, developed the Block Project, where we provided syringe exchange, drug treatment, HIV, STD counseling, testing, and linkage to care to women who were working in the nightclubs. Over the years, that program actually expanded, and those services began to be offered through our mobile unit to other women who accessed our program at the various sites that we visited throughout Baltimore City, Monday through Saturday. So, in collaboration with the University of Maryland, the Baltimore City Health Department STD team, Johns Hopkins Hospital, and Johns Hopkins University, we got volunteer medical students who come on our mobile unit and work on the Block Project. They provide pregnancy testing, emergency contraception, Depo-Provera shots, testing for syphilis, gonorrhea, and chlamydia, and other health services as well, mental health, other mammograms, breast exams, any reproductive or sexual health services that a woman may need and she may have limited access or no access to health care, we can provide those services from our mobile unit. We also partner with the Field Health Service Program here at the Baltimore City Health Department, where again, we provide vaccines for hepatitis A, B, and C. We do flu shots during the flu season as well as tetanus shots. We also work with Healthcare Access Maryland, again, where they have case managers that come on our mobile unit to work with the community as well as the young ladies working in the clubs who may need birth certificates, state issued identification, or if they need any other support services, we provide those services from the mobile unit. Again, while this project is specific to the Block and the women working specifically in the clubs, those services are offered on our mobile unit to anybody that can access any one of our mobile sites or that can meet our mobile unit on Thursday nights when we're stationed down in front of the clubs on the block. And just wanted to give you an idea of what our mobile unit looked like. This is our mobile unit actually parked outside of the block on a regular Thursday night. The other picture is the inside, as you can see in the very back. We have an exam table, and it's sort of set up like a mini exam room where again there's some confidentiality. If there is a urine sample that needs to be taken, there is a bathroom that is on the mobile unit as well. Any confidential information, there's a door so that there's some privacy for the women if they're having a mammogram or a pap smear taken. So again, we try to make it as comfortable for the women as possible, because again, we know for a lot of these ladies that they have limited access to health resources. And if we can take services in the community to these women, we definitely want to try to do that to ensure that they're getting the comprehensive care that they need. And again, this is just an idea of what the block looks like. We typically park somewhere between the Hustler Cub and Club Pussycat. And again, some of the lessons that we learned is, again, we need to ensure that services are physically accessible and no cost or low cost and offered in a non-judgmental environment. We don't have any criteria for the women to come on. Again, If they're clients of the Syringe Exchange Program and they're active injection drug users, of course, we offer those services. But if they're women in the community who may not be injection drug users but use other substances, or just low-income community members who need assistance with reproductive health, they're welcome to access our mobile unit and receive services as well. Again, also in making sure that we provide education. We are a harm reduction program, so we do provide education around harm reduction, prevention, and sexual health and wellness, and making sure that we provide informed choice and consent. So we are a confidential program. We don't provide any services unless we get the full consent of the clients that we're providing services to. We also make sure that we respect and protect the client's confidentiality and their privacy. So if there is a need to refer them to other services, we do get their written consent. And again, respecting and treating the clients with dignity. One thing that we have learned over the years, in the 26 years that our program has been in existence, is that while these women may be commercial sex workers, while they may be active injection drug users, they're still women. And they still deserve to be treated with dignity and respect, and they still deserve to have services provided to them like any other woman in any other way. So we're very, very serious and it's very important in the way and the manner that we provide services to our female clients, that we want to make sure that they feel comfortable, that they can come to us and talk to us, and that if there are additional services that we need to provide to ensure their safety and their health, that we can also provide those services. And that's pretty much it. This is my contact information, so if there's any other information that I can provide, please feel free to reach out.
Thank you so much, Lisa. That was a lot of good information. I have some questions for you. Can you speak to the differences? And so, like, do you target areas where you know you might be servicing more women? Because your data showed that you're seeing more men. How has that changed over time?
Well, I think over the past few years, our demographic information has sort of changed a bit. We are seeing a younger population and a younger female Caucasian population, which I think speaks to the opiate epidemic happening in Baltimore City right now. We don't target any specific community or population. We follow the data trends, and we also follow what our clients tell us. We do regular check-ins with our clients. If they know areas in the community where we may not be providing services, and they can give us suggestions as to where we need to be, we'll send an outreach team out. We'll kind of do some blanketed outreach in those areas to monitor the traffic, to see what's going on, and then we'll take the mobile units in, or we'll partner with local faith-based organizations or community-based organizations to provide syringe services, to do overdose prevention training and distribute naloxone, or just provide harm reduction education. But we don't, again, our targeting is just following data trends, following overdose trends, where there's upticks in HIV, STD infections, and those type of things.
Got it. That makes sense. So do you have a schedule for where the mobile unit is going, or like, do you have a set schedule for some days and then more of an open schedule other days, or is it always open?
So we do have a set schedule. We operate Monday through Saturday. We modified our schedule because of COVID. Typically we'd operate from 8:30 to 4:30, but because of COVID, we've cut back some of our hours, where we would typically go have 2 mobile units out during the course of the day and see 4 sites. We're now down to 1 mobile unit, and we're visiting 3 sites a day. We also have an evening program where we go out 4 evenings a week. And again, the schedule has been modified from 4 hours an evening to 2 hours, and on Saturdays as well. So we're out several times a week. We have set sites, and most of those sites are areas throughout Baltimore City where there's high incidence of drug traffic, high overdose rates, high police presence, and a lot of times the police will reach out to us and ask our program to come out because of the drug traffic and overdose and HIV, STD infection rates in the community.
Okay, that makes sense. Thank you. And then I have one last question, and it's about how, when you're doing the initial engagement with women, do you have a script or a form or something that you go through to make sure that you cover all of the possible services that you could provide, or is that more of an organic conversation?
We do have a set script, but it's more organic. It's more of engagement, based on what the woman may have come to the mobile unit for. Sometimes they come out of curiosity. They may be a little shy at first because they know that the mobile unit, because there's several mobile units actually in Baltimore City. Some do specifically HIV testing. Ours does, again, syringe exchange, and some do other health services. So they may come and just engage the staff, and as we have the conversation, we'll talk about the multiple services that we provide and try to develop relationships. One of the things that our program is very big on is developing relationships and community engagement. So we never go in, with the mindset of this is just how we're going to do things. Again, while we have a script, we, again, organically, whatever the need is that we can address, we work that way versus this is just how we're going to do things and that's it. So we operate a little outside of the box sometimes.
That's great. I have someone said in the chat, bravo, Baltimore. So you can bring those compliments back to your colleagues as well.
Absolutely.
Thank you, Lisa.
You're very welcome.
Deena, it's your turn to talk about the work that you're doing with the criminal justice system. You're muted, Deena.
Hi.
There you go. Okay.
Okay. The universe is conspiring against me today. Everything that could possibly go wrong with my computer has gone wrong. I am now sitting in my living room floor. This is my fourth location. So I hope that everybody can hear me. I don't have slides because our process for getting a slideshow approved is very long, and I didn't think that I would be able to get anything approved before we came on today. So I'm just going to share with you some information, and I'm happy to answer any questions. I will tell you that I am brand new to the Title X Family Planning Program for the state of West Virginia. I have been the interim director for just 6 months. So a lot of this information is even new to me. I have been working on one of the grants for a couple of years, but in a different role. I was the director of the Adolescent Pregnancy Prevention Initiative, which operates under the Family Planning Program. We do all of their community outreach and education. So as part of that role, I was working with one of the grants that I'm going to tell you about. So I'm a little bit more familiar with one than the other. So I'm going to share. I've got notes because I don't have a slideshow. So I'm just going to share with you. There were 2 grants awarded in 2018. They were part of a state targeted response. About $5 million of funds were allotted through the Substance Abuse and Mental Health Services Administration. And they were given to the Office of Drug Control Policy, who in turn granted the Family Planning Program 2 grants, one to work with corrections facilities and the other to work with harm reduction clinics. And the reason for these grants, obviously, the opioid epidemic is everywhere, but West Virginia was particularly hard hit. And what we found was that about 7 out of every 50 babies that were born were exposed to some kind of substance, whether it be prescription drugs, illicit drugs, heroin, some type of opioid. There was just so much exposure that the increase in neonatal abstinence syndrome was just through the roof, and something had to be done. So they started with harm reduction clinics. And this was a voluntary thing. The harm reduction clinics that are in West Virginia were provided with the information, and we had 11 harm reduction clinics sign up to participate. So in that first year, there were 11 clinics that received some training. They signed an agreement with us that in addition to providing that harm reduction, they would also work with the family planning program to provide reproductive health services. So I don't have numbers. What I do have is that 10 of the 11 clinics, of course, the goal of the grant was to reduce the number of NAS births in the state. And with any new grant program, you're going to have challenges, and you're probably not always going to meet the goals the first years. But the biggest setback for the harm reduction clinics was that the largest number of their participants that they were seeing were older males. They weren't seeing women of reproductive age in their harm reduction clinics. So several of the clinics that initially signed up with us to be participants in this grant program have said that the people that they see are not the people that we're trying to reach. So a lot of those dropped out in the first year, and this year we don't have as many clinics participating with us. But we are seeing a little bit better results from those that are participating this year. So hopefully with a little bit more education, a little bit more talking about these things, we can really work on that. All of you all seem to be making this work in other ways. It's giving me lots of great ideas, and I plan to reach out to some of the other presenters later in the week to get some more ideas. Like I said, I'm brand new to the family planning administrative role. So that is, what you're doing is very inspiring, reaching out into different areas of the community and targeting those people that can make a change, which will definitely impact the numbers. That's something that I hope that we're able to do with these harm reduction dollars, because we have somebody there ready to fund it. It's just not been approached in those ways that I'm hearing from you all, and it's very inspiring. Now, the corrections grant is one that I'm more familiar with. So I'll give you a little bit of information about that one. Again, the Office of Drug Control Policy is where the funding came from. And from June of 2018, which is when we started that corrections grant, we have a regional jail facility and Lakin Correctional Center, which is a women's facility participating. We have another facility that will join later this year. But from June of 2018 to now, there have been 2,278 inmates seen by a family planning provider in those two locations. They've been given education about reproductive health. They've been given contraceptive methods. We have done 1,616 pregnancy tests, and 740 women of childbearing age were provided with at least one method of contraception. So we have made some accomplishments there. And another thing that I'm really proud of is the education part, because we worked with the providers and gave them some kind of what we use for community outreach and education for teens, kind of adapted it to that inmate population. But we also had our adolescent pregnancy prevention workers going into the facility and doing classes. And we developed kind of a two-part series that the women had to complete before they could go up for parole or probation. This was a requirement from the warden after he viewed one of our programs. And I think it really made a huge difference, because some of these women have never been spoken to about their reproductive health. They didn't know anything about all of the different options that there were for birth control. It's just something that they just didn't know about. Some of these women that came to our classes have been incarcerated since they were 18. So they didn't know that there were other options available. Some of them were grandmothers who had granddaughters that they were concerned about and wanted to be able, when they got out, to share those options with those granddaughters. So that was a really rewarding program to be a part of. And of course, when COVID hit, that kind of changed the dynamic of that because we're not allowed in the facilities now. But we did training for about 60 women at Lakin Correctional Facility, and we trained 12 staff. And so I think that was pretty successful. I was really pleased with that. And I hope once things kind of calm down a little bit that we're able to start that back up, because I really think that it made a difference for those women that we were able to work with. So let me make sure that I've covered all of that. Really the challenges that we saw with the corrections facility was maintaining a provider there on a consistent basis. When there's no provider, that limits the inmate's ability to go to the medical facility. If there's not a provider on staff, there's a lot of things they can't get. So we had a couple of provider issues, which that's why the third group has not been participating for this 2-year grant period. They're joining now because they just got a provider on board. So that's been a real issue. The program that we presented was voluntary for the inmates. They had to sign up to participate, and they had to attend both sessions for it to count towards their probation parole requirement. We worked with underage offenders, 18 to 21, not exclusively, but for those people, they were housed at Lakin due to construction happening at the facility where they normally house the youthful offenders. And their warden just thought the program was so important that he made it a requirement for those particular offenders. They had to attend the program. And when he did that, the warden at Lakin also followed suit and said, if you're going to be paroled out into a community, you need to know what's out there. So we taught about family planning access. We taught about the different birth control methods, where you can go, who you can talk to. And of course, once they get to the family planning program, all of the other community resources that are available to them, they can get from those family planning providers. They're very well versed in making referrals for different things, and they know a lot about the community resources that are out there. And as one of you said in your presentation earlier, for many women, that family planning contact, that family planning provider may be their only medical provider. That may be their medical home. So we try to make sure that they are very well versed about what's out there in the community, what resources are available, especially for a woman who's just returning to her community. She's not going to know where to go and who to talk to get birth control or to get really anything else. So we do try to make sure that they have up-to-date resource listed and that they're well connected with their community partners so that we can make sure women are being taken care of. But that's kind of us in a nutshell. And I'm sorry, I don't have slides or tons of information. Like I said, I've been doing this 6 months. So that's kind of what we're doing in West Virginia. It's very new. June of 2018 is when we started. I think there's a lot of potential for growth. Like I said, the funding is there. And you guys have given me some really great ideas. So I'm so glad that I was included in this. I don't know how much information I've given to you, but it's certainly been helpful to me.
Thank you, Deena. Can you share more about the actual facilities that you're working in and whether they're like county facilities or state facilities, and how you went about either picking those facilities or if they volunteered themselves, like one of the wardens was really interested? That kind of engagement process, I think, would be really helpful for.
Okay, so the first facility, Lakin Correctional Center, is a prison. It's not a jail, it's a prison. And it's an all-female prison. And it was really fortunate for us, not fortunate for the ladies. But at the time when this program started, Alderson, which is an inmate population that is underage, under the age of 21, they were undergoing construction and they had moved their population into Lakin's facility. So we had access to those youthful offenders. And that's what sparked the interest for the warden. It was initially that we could have access to those women. But when he saw the program and what we were doing, he was like, all of these women need this. And so he expanded that. But it was voluntary for the inmates. It wasn't something they were made to attend. They did a flyer. They told them what we were going to be talking about, and they signed up for the flyer, signed up to attend. One of the comments that we got, which really was exciting for me, was after the first presentation that I did, we had the same guard that went into the room with. We're required to have an armed guard anytime you're alone with the inmates. And I had 37 women, I think, in my first class. And when we left and she was walking me out, she said, I have never in all the years I've worked in the prison seen these women behave in a class like this. She said they all paid attention, they all participated. It was wonderful. And I learned things that I didn't know. So that made me feel really good, like we had really accomplished something. And I always had really good attendance, and they were always super well behaved. I never have any, there were never any discipline issues, because this is a topic they were genuinely interested in. The other two facilities that we work with, Taggart Valley Regional and South Central Regional, are regional jail facilities. So when we go in to do education, it's typically geared towards the women, but it's only because we haven't been asked to do it for the males. We do have it available for the males. We do provide condoms that they can give out to the males, and they also give condoms to the women. But we haven't been asked to do the educational piece for the males at this point. And as I said, we're 2 years in. South Central is just now coming on board. So hopefully that will be something forthcoming. Now, we have worked with the day reports and the youth reports in the area, not through this grant, but just through family planning. And we do that they will call and ask if somebody can come and talk to their participants about reproductive planning, life planning, how can we access family planning services, what's available in the community. So those three facilities, we put out the word through Department of Justice and Division of Corrections that we were going to do this. And those were the three facilities that responded to us. And we really haven't done a lot of promoting or trying to get somebody in, because we weren't sure how that would work or how much it would cost. We could do more. And I think Department of Corrections is willing to do more if we could get, if we can get people to participate in that way.
Thank you so much. So can you summarize again what, if any, clinical services are provided?
Yeah, they call it medical, that we're going to go to medical, or we're going to get, a slip to go to medical. When they go to medical in Lakin, they have full, just like they were in a family planning clinic, they have full reproductive health services available. Now the jails are sometimes a little more limited, again, because of the provider. If they have a provider, they have full family planning services available to them. If they're lacking a provider, they may not be able to get that. Right now, all three have a provider, so they're getting full family planning medical.
Got it. Thank you so much.
You're welcome.
So at this time, I would just like to open it up to other panelists, and you can ask each other questions or give some closing thoughts or anything like that, because we're scheduled to end at 2:30, but it's only so if anyone has any other questions or closing thoughts, I would love to have you share them. And then if not, I will close the session. Any closing thoughts? I saw in the chat that one of our participants and former presenter, Karen, shared the news that Purdue is going to plead guilty and result in $8 billion of fines. So that's great. Okay, so I don't see any other questions and no one is unmuting themselves. So I'm just gonna thank our presenters. And, oh wait, there is a question, hold on. Wondering if any agency is working to try to clear women with opioid use disorder of their hepatitis C prior to getting pregnant. I think maybe Laurel or Tanya, if you can address that question, if you have any focus on hepatitis C treatment, especially for women who you know might be planning to get pregnant.
We actually, this is Laurel, we are in the beginning stages, as Tanya kind of presented earlier. Planned Parenthood has a medical team that kind of looks at these different areas. And so we are in the beginning stages of actually starting to at least provide testing for hepatitis C, which is kind of the first step. And then hopefully once we find and are able to do testing, then potentially able to move in the direction of providing treatment as well. But we're really at the start of that process of potentially doing testing for hep C.
Thank you, Laurel. Lisa, can you speak to that? Do you do any targeted hep C testing?
We are actually just in the same space as Laurel. We're beginning to do hep C testing on our mobile unit, and actually we collaborate with one of the other mobile health units, a program called the SBIRT Van, which is a mobile clinic that works through Johns Hopkins. They actually support us in doing hep C testing, but probably once we get through the COVID pandemic here in Baltimore, we'll be doing hep C testing on our mobile unit as well.
Great, thank you. Okay, I think that is it for questions. And again, I would just like to thank all of our presenters and thank everyone who spent time with us this afternoon. I will send out information on the presentations and slides and evaluations like that probably next week. And our next session in November will be a facilitated session that will help different programs come up with developing like a work plan for their interventions that they might be interested in. So we're trying to turn all of the knowledge that we've shared with everyone into action. So we'll be working on some action plans that might turn into new programs. Okay, thank you, everyone.